Now let's take a look at the top of the digestive system. We'll begin with the mouth down through the esophagus. The mouth is known as the oral cavity or buccal cavity, and it has many functions, obviously including ingestion of food. It has sensory responses to food, such as taste buds on the tongue. It's involved in chewing and chemical digestion. Starch is partially digested in the mouth by saliva. It's also involved in swallowing, speech, and of course respiration. It's enclosed by the cheeks, lips, palate, and tongue, which we'll examine here soon. The oral fissure is the anterior opening, so the mouth is basically the oral fissure. The fauces is the posterior opening to the throat. The majority of the mouth is covered by stratified squamous epithelium. It's keratinized in areas that are subject to a lot of abrasion, such as the gums and hard palate. And it's non-keratinized for most of the rest of it, the floor of the mouth, the soft palate, and inside the cheeks and lips. Let's look at the cheeks and lips. The cheeks and lips are going to retain food and push it between the teeth for chewing. They're essential in the formation of speech and for sucking and blowing actions, including suckling by infants. The fleshiness of the lips is mainly due to the buccinator muscles and the orbicularis oris. There are two little attachments where the lips are attached to the gum line, the labial frenulum, both on the superior lip and the inferior lip. The vestibule is the space between the cheeks and lips. So if you were brushing your teeth on the outer surfaces, you would put your toothbrush in the vestibule. The lips are divided into three main areas. There's the cutaneous area, the red area, and the labial mucosa. The cutaneous area is the outside. It's where a mustache would be. It has hair follicles and sebaceous glands. The red portion of the lips is where the lips meet. It's the area that we might put lipstick on. They have tall dermal papilla, which allow the blood vessels and nerves to come very close to the surface. This allows them to be much more sensitive and also lends to the red color. The labial mucosa is the inner surface of the lips, facing the gums and teeth. The tongue is a muscular and bulky but really agile organ. It's used to manipulate food between the teeth, and it avoids being bitten. We can extract food particles from the teeth after a meal, and it's very sensitive. So sensitive we can feel such thing as a stray hair in a little bite of food. It's mostly made of non-keratinized stratified squamous epithelium. There are little bumps all over its surface called lingual papillae, and these are the sites of where we will find taste buds. However, we covered taste buds in a different chapter. The body of the tongue is the anterior 2/3, and it occupies the oral cavity. The root is the posterior third of the tongue, and it occupies the oral pharynx, and it's attached by many muscles into the hyoid bone. There are velate papillae, which is a V-shaped row of papillae that mark the boundary between the body and the root of the tongue. In this same region, we'll see the terminal sulcus. There's the lingual frenulum. The frenulum, again, is a little fold of skin that attaches the tongue to the body or the floor of the mouth, similar to the frenulum on the lips. There are intrinsic muscles that are entirely within the tongue, and those are the muscles that are involved in producing the tongue movements of speech. And then extrinsic muscles with origins elsewhere and insertions in the tongue. So, for example, the hyoid bone, and this allows the tongue to produce the much stronger movements that are necessary for food manipulation. There are also lingual glands that secrete mucus, and there are lingual tonsils contained at the root of the tongue. The palate is the roof of the mouth that separates the oral cavity from the nasal cavity. It allows us to breathe while we're chewing food. There are two portions. There's the hard palate and the soft palate. Now, the hard or bony palate, you'll remember, is formed by the transverse processes of the maxilla as well as the palatine bones. There are little ridges all over the roof of the mouth. Those are the palatine rugae. The soft palate is further back. It has more of a spongy texture. You can reach your tongue back and touch it. There's no bones in there. It's mainly composed of skeletal muscle and glandular tissue. From the soft palate, we have the uvula that hangs down. It's thought that the uvula is there to retain food in the mouth until one is ready to swallow. There's a pair of muscular arches on each side of the oral cavity. The palatine tonsils are located right in between the two. The palatoglossal arch is the anterior arch, you see here, and then behind that, the palatopharyngeal arch, which is the posterior of the two arches. Now on to the teeth. Dentition. The teeth are used to masticate food, break it into smaller pieces, and this makes it much more easy to follow, and it also increases the surface area so that it aids in digestive enzymes reaching as much area of food as possible. Now, the teeth or dentition. The teeth masticate food. They break it into smaller pieces, which not only makes it easier to swallow, but exposes more surface area of the small. Now, the teeth or dentition. Teeth are used to masticate food, that is, to break it into smaller pieces and make it much easier to swallow. The act of chewing the food into small pieces also increases the surface area of the food so that the action of digestive enzymes can be quicker. There are 20 baby teeth, which are deciduous, and then there are 32 adult teeth. In the adult, that leaves 16 in the mandible and 16 in the maxilla. From the midline to the rear of each jaw, we start in the front with 2 incisors, which are chisel-like cutting teeth used to bite off a piece. The canine teeth are used to puncture, shred, and tear. There's 1 of those on each side. There are 2 premolars, which have broad, flat surfaces that are used for crushing and grinding. And then 3 molars, which have even broader surface for crushing and grinding. Now, the teeth themselves are formed from a gomphosis joint. You'll remember that from last semester when we studied bones. The gomphosis joint for the tooth is called an alveolus. The tooth is held in place by a periodontal ligament, which is modified periosteum, whose collagen fibers are going to penetrate into the bone of the jaw. It anchors the tooth firmly in the alveolus and allows slight movement under the pressure of chewing. The gums, or the gingiva, covers the alveolar bone. Now, there are distinct regions of the tooth, which are defined by where the gum, or the gingiva, meets the crown and the root meets the crown. So the crown is the portion above the gum. The root is the portion below the gum. The gingival sulcus is the space between the tooth and the gum. That's the area that a dentist might measure the depth of to determine the health of your teeth and gums. Periodontal disease is where we damage the periodontal ligament. More on tooth structure. Dentin is this hard yellowish tissue that makes up the majority of the tooth. Enamel is a substance that covers the crown all the way down to the neck, and this is a secreted substance before the tooth erupts. Cementum is the hard covering over the root. Cementum and dentin are living tissues, and thus they can regenerate. They have a blood supply that enters through the apical foramen. The root canal is the space in the roots leading into the pulp cavity. It's full of nerves and blood vessels. Here in this figure, you can see some baby teeth or deciduous teeth, and above or below them, deep in the gum line, we can see the emersion of adult teeth. These 20 deciduous teeth are going to develop between the age of, or erupt between the age of 6 and 30 months. The incisors come first. And then between the age of 6 and 25, those teeth are going to be replaced by our permanent adult teeth. Often the wisdom teeth can become impacted because of crowding in the gum line. And so they can't grow up past the neighboring teeth, and that's why we often will have our wisdom teeth removed. So there's an amazing number of microorganisms living in our mouths. They say more than 700 different species, mostly bacteria. These bacteria live on the sugars and such that we consume. And the bacteria combined with the sugars is what causes plaque. Calcified plaque is called a calculus. These bacteria in the plaque are going to mobilize sugars and release acids. These acids can dissolve the minerals of the enamel and the dentin, and that causes cavities or dental caries. Sometimes the cavity will reach as deep as the pulp. In that case, root canal therapy is necessary. Sometimes calculus or calcified plaque gets into the gingival sulcuses and wedges the tooth and the gum apart. This allows more bacteria to invade the sulcus and lends itself to gingivitis. So teeth are used in the process of mastication or chewing. Mastication is again breaking food into smaller pieces so that the enzymes of digestion can access it more easily. Mastication involves both mechanical and chemical digestion. Food is going to stimulate receptors in the mouth that trigger an involuntary chewing reflex. In addition to that, things like the smell and the sight can also stimulate the salivary reflex. So now we move on to talk about saliva. Saliva keeps the mouth moist, and it has contents that will begin to digest starch and fat. Keeping the mouth moist aids in keeping the surfaces of the teeth clean and inhibits bacterial growth. It also dissolves molecules so that they can stimulate the taste buds. And saliva is involved in moistening food and binding it together into a bolus and aid in the swallowing of that bolus. Generally, saliva is a hypotonic solution, results from capillary filtration predominantly. It's about 97% to 99.5% water. And it contains some of the following things. It contains an enzyme that's used for starch digestion, and it begins in the mouth, salivary amylase. There's also lingual lipase. This enzyme is activated by the stomach to digest fat after the food is swallowed. So saliva acts to begin starch digestion in the mouth and doesn't begin digestion of fats until it reaches the stomach. And that's because these enzymes are pH dependent. So the salivary amylase functions best at normal pHs that we see in the mouth. However, the lipase acts much more efficiently at very low or acidic pHs. We'll also find mucus in the saliva, which aids in binding the bolus of food together. Lysozyme is an enzyme that kills bacteria. Also, there's an antibody that inhibits bacterial growth called immunoglobulin A, or IgA. And the saliva will also see electrolytes: sodium, potassium, chloride, phosphate, and bicarbonate. There are many salivary glands. There's intrinsic salivary glands, which are small glands that are mixed up amongst the other tissues in the mouth. And then there are extrinsic salivary glands, which are 3 distinct pairs that are connected to the oral cavity by ducts. The intrinsic salivary glands, we'll see some in the tongue. Those will produce lingual lipase. We'll see some in the labial glands, so salivary glands inside the lips. In buccal glands that are inside the cheeks. And all of these secrete saliva at a fairly constant rate, keeping the mouth moist and the teeth clean and so on and so forth. The three pairs of extrinsic salivary glands are the parotid, submandibular, and sublingual glands. The parotid glands are located beneath the skin, just in front of the earlobes. These are the glands that swell in the event of mumps, when the gland becomes inflamed by a virus. The submandibular glands are located halfway along the body of the mandible, and they have a duct that empties at the sides of the lingual frenulum, so right near a piece of skin that holds the tongue to the bottom of the mouth. The sublingual glands are located on the floor of the mouth. They have multiple ducts that empty posterior to the papilla of the submandibular duct. You'll see here sublingual ducts, the submandibular gland and its duct, and then the parotid gland here in the cheek and its duct. Salivary glands are tubuloacinar glands. If you remember, acinar refers to the sacs at the ends, and the tubular part refers to the tube. So they're a combination of both tube and sacs. And the cells in these sacs are either mucus cells or serous cells, or you can see in this case mixed acinar cells, where both mucus and serous cells exist. The mucus cells obviously secrete mucus, but the serous cells are going to secrete most of the enzymes and electrolyte. We produce a lot of saliva each day, 1 liter to 1.5 liters. The cells of the acini are going to filter water from the capillaries around the mouth. The cells of the acini are going to filter water and electrolytes from the blood and add amylase, mucin, and lysozyme. There are salivary nuclei in the medulla oblongata and the pons. These respond to signals generated by the presence of food inside the mouth, either the tactile or the pressure of food, and then taste receptors. They receive also input from higher brain centers with odor and sight and thought of food. All of these things stimulate salivation. Signals are sent by autonomic fibers in the facial and glossopharyngeal nerves to the salivary glands. The parasympathetic fibers are going to stimulate the glands to produce an abundance of thin, enzyme-rich saliva. As you know, parasympathetic, remember, is rest and digest, so this makes sense. Sympathetic stimulation is going to stimulate the glands to produce less saliva and much thicker saliva with more mucus. Hence, when something's scary, we have the sympathetic response, a light, we get a dry mouth sensation. The bolus is the mass of food that's swallowed as a result of saliva binding the food particles into a soft and slippery, easily swallowed mass. So now on to the pharynx. The pharynx is where we see the digestive and respiratory tracts intersecting. It's a muscular funnel that connects the oral cavity to the esophagus, and it allows entrance of the air from the nasal cavity into the larynx. There are several muscles involved in forcing food down during swallowing. We'll visit those here soon. So now on to the pharynx. The pharynx is where the digestive and respiratory tracts intersect. It's a muscular funnel that connects the oral cavity to the esophagus, and it allows the entrance of air from the nasal cavity into the larynx. The pharyngeal constrictors are the muscles of the pharynx, and they force food down while swallowing. When we're not swallowing, the inferior constrictor remains contracted, forming a sort of sphincter, although it's not truly an anatomical sphincter. because it's just a constriction of this inferior constrictor muscle. It disappears at the time of death when muscles relax, and so it's considered to be a physiological sphincter rather than an anatomical structure. The esophagus is a straight muscular tube. It's 20 to 35 centimeters long. It's lined with non-keratinized stratified squamous epithelium and covered in muscle along its length. It's got skeletal muscle in the upper 1/3, where it's voluntary action, a mixture of skeletal and smooth in the middle third, and only smooth muscle around the bottom 1/3. In the second and third thirds, there is little voluntary control. The esophagus begins at the level of C6, right by the cricoid cartilages, you'll remember from respiration. And it meets the stomach at the level of the thoracic vertebrae number 7. It extends from the pharynx down to the cardiac orifice of the stomach, which is named for its proximity to the heart. The lower esophageal sphincter is at the bottom of the esophagus, and food pauses here for a moment. This valve prevents stomach contents from being regurgitated into the esophagus, and thus it protects the mucosa from the erosive effect of stomach acid. This is where we feel heartburn. If this sphincter allows acid to reflux into the esophagus, we get this burning sensation. It has nothing to do with the heart. The esophagus is covered by adventitia, which merges into the adventitias of the trachea and the thoracic aorta. So how does swallowing work, or deglutition work? It involves the complex action of over 22 different muscles in the mouth and pharynx, and it's coordinated by the swallowing center in the medulla oblongata. The swallowing center communicates via the trigeminal, facial, glossopharyngeal, and hypoglossal nerves. But you don't need to memorize those. Swallowing occurs in 2 phases. We have the buccal phase, the pharyngoesophageal phase. The buccal phase is under voluntary control. So the tongue collects food, and it's going to press it against the hard palate and form a bolus. And then as we swallow, the tongue pushes that bolus posteriorly, and food is going to accumulate in the oropharynx, right in front of the epiglottis. The epiglottis will tip posteriorly, and food will slide around it through the laryngeal opening. As the bolus enters the laryngopharynx, it stimulates tactile receptors and activates the next phase. The pharyngoesophageal phase is involuntary. There are 3 actions that prevent the food from re-entering the mouth or entering the nasal cavity or larynx. We have, first of all, the tongue blocking the oral cavity, and the soft palate raises and blocks the nasopharynx. And the infrahyoid muscles are going to pull the larynx up to meet the epiglottis, where the laryngeal folds close the airway. The food bolus is driven downward by constriction of the upper, then middle, and then finally the lower pharyngeal constrictors. The bolus enters the esophagus. The esophagus becomes stretched, which stimulates peristalsis. Peristalsis is the action of the esophagus contracting against the bolus of food and pushing it down. When we're standing or sitting upright, the food and liquid drops pretty much on its own, aided by gravity, faster than the peristalsis can keep up with it. However, if we're lying down or even standing on our head, peristalsis ensures that you can swallow. Liquid could reach the stomach in 1 or 2 seconds, and a whole big bolus of food might take 4 to 8 seconds. When it reaches the lower end of the esophagus, the lower esophageal sphincter relaxes and lets the food pass into the stomach. Here's an x-ray of swallowing in the esophagus. You can see the upper esophagus, the peristaltic contraction, and then pushing of the food down through the esophagus. That completes the upper digestive functions. Next, we'll move on to the stomach.